I'm Abdussalam Turjuman. Our presenter today is Prof. Saleh AlObeidan. He's a glaucoma and cataract consultant at King Saud University. He will be talking about practical pearls in glaucoma surgery. Please, Prof. Saleh.
Okay, thank you very much. Bismillah ar-Rahman ar-Rahim. Thank you very much, Abdussalam, and good afternoon to all of you. It's my pleasure to share with you today some important practical points that should make our daily work as a ophthalmologist is more safe to our patient and more stressful to us. The content of this lecture is directed mainly to the colleagues, junior colleagues in training, residents and fellows, as well as those who are already recently graduated, as well as general ophthalmologists in general. Before I start, I'll give just short overview to all of us that we know that all of us know that the glaucoma is the major or the leading cause of irreversible blindness worldwide. No doubt about that. And glaucoma being a silent disease in vast majority of its forms, the only available way to prevent damage caused by glaucoma to our visual functions is early detection. So once the disease is detected, effective treatment is available, whether medical, laser, or surgical. However, as you know, the traditional approach, as well as classical teaching, is to in managing the glaucoma is to start with medical therapy, medical therapy, laser, and so on. However, this nowadays, based on evidence-based reports and so on, is not the exact practice. So, as we will see later. However, in certain cases like primary angular closure and primary angular closure glaucoma and some forms of secondary angular closure glaucoma with the pupillary block, laser and surgical iridotomy is mandatory for these cases. You know, trabeculectomy is the gold standard procedure, being that because it is the most common procedure done worldwide as a surgical procedure for glaucoma. However, with the new modifications of old or traditional glaucoma surgeries, as well as the newly emerging glaucoma surgeries, especially non-penetrating glaucoma surgeries, in particular, the deep sclerectomy have maintained the efficacy of this gold standard glaucoma procedure with high safety profile. It's not only that, I mean, making the surgery is more safe to our patients and effective, but also it's changing our management approach to the disease. In the past, as I said, medical therapy, laser, and I remember not far away back when I was resident or during my residency and early in my practice as a glaucoma specialist, we don't consider surgery until we use all available anti-glaucoma medications, including systemic medication, I mean carbonic anhydrase inhibitor. Then if the disease is still not controlled, we go for surgery. You can imagine how the eye is gonna be, how long you have been delayed the intervention or the most appropriate procedure. Probably this is acceptable during in the past because of the glaucoma procedure at that time, like, I mean, full thickness procedures, refining of the sclera, and so on, associated with significant risks of serious complications after the glaucoma surgery at that time. Nowadays, these pictures have changed significantly. When we look to the indication, and this is, you can learn what do we mean by that? You know, when we look to the broad indication that uncontrolled for intervention, uncontrolled intraocular pressure or documented glaucoma progression despite maximum, I would say, sorry, maximum here, tolerated medical therapy. What do we mean by maximum? The patient that can tolerate, but is the patient going to use them in or stick to them in a accepted way? For example, you can put yourself or imagine yourself one of these patients to use, for example, 3 or 4 topical anti-glaucoma medication. I will not say systemic medications, some of them to be used twice a day, and to stick to the timing. It's impossible. It's impossible. So what we are doing, in my opinion, is just delaying the appropriate management or treatment for the disease until it reaches a late stage. And this is most of the time what we are seeing. So yes, and then the other indication that they say poor compliance with medical therapy, which is relative indication. And the advice is to maximize compliance first before you consider surgery. Again, this strategy probably I'm not with. So a patient who is probably is not knowing, despite you explain to him the nature of his disease, and he's not sticking to or taking his medication or therapy in appropriate way, don't try again to say I will give a chance or so. Go and intervene. Go intervene to preserve what remained of his visual functions. Pupillary block angle closure glaucoma. Traditional speaking or teaching or practice to do laser radiotherapy first, then give medication if there is a residual elevated intraocular pressure. This is in the past. Nowadays, and evidence-based reports showed that the what you would call it, probably the better preservation of visual function with surgical intervention. What I mean, probably the term is not in my mind, but when you, in such cases, the intervention or surgical intervention is much better than traditional way to go to do iridotomy. Then if there is still IOP is elevated, you can give medication. If not, then you can go for surgery. This is similar also. Evidence-based reports said that, and this is not even recently, that surgical intervention superior, yeah, this is the terminology that I'm looking for, superior to the medical and laser therapy in open-angle glaucoma. So, of course, you cannot, make it as a rule for all cases. You need to individualize cases. For example, as an old man who is, very old, and he's, for example, bed restricted and so on. Probably, yes, and somebody taking or caring about him, it's okay. But in active stage of the or age of the patient, you cannot, stay or to say that I will give medication or go with the traditional way of management and see what's going on. What we are doing in this way, we are delaying the appropriate intervention. So now the practice is changing. So as we will see later. So yeah, again, cynical angle closure, one of the indication for 360, and they said my go straight. Of course, definitely, you don't need to waste time and spend time to trying to control the pressure with medication or with laser, YAG laser or whatever. And we know this type of disease is very destructive. So optimize your patient and take him to or give him the appropriate care, which is a surgical intervention. Congenital glaucoma, of course, all of these patients need surgical intervention. So now we'll take more, or to come more to the topic that I would like, or to the message that I would like to send to you or to give it to you. Glaucoma or trabeculectomy is the gold standard procedure in all glaucoma surgeries. And why being like this? Because it is the most common type of glaucoma surgery done worldwide. However, complication can occur with the trabeculectomy, as well as with other newly emerging techniques, whether non-penetrating glaucoma surgery, tube surgery, lasers also, and some of these complications can be vision-threatening complications. So we need to, I don't know, this is coming in front of the screen or not, anyhow, threatening complications. So how can we make our glaucoma procedure, whether trabeculectomy, non-penetrating, tube, laser, and so on, more safe to the patient and much less stressful to us? There are general things for all procedures, whether glaucoma or non-glaucoma, which are the preoperative precaution in all ophthalmology procedures. First, we need to identify patients at risk. At risk, what do we mean by this? Through their systemic condition, evaluation of their systemic conditions, such as systemic hypertension, diabetes, anticoagulants. We need to optimize a patient to make the surgery more effective and less stressful to us, as well as to choose. This is all in the clinic. Imagine yourself facing a patient in the clinic and you decided to go for intervention. So you need to take these in consideration. Anesthesia selection also. Don't take this or delay the type of anesthesia until you get the patient in the OR. So patient, am I going to give local anesthesia? Peripalpal, retropalpal, subtenon, topical, or general anesthesia. Depends on the case, from systemic condition as well as from ocular conditions. Surgeon selection also. In the clinic, before, everything should be written in the file of the patient, what we are going to do. Am I going to do, the surgery to be done by consultant or by trainee? This is, for example, one-eyed patient. I think it's not wise to let the trainee to do it, even under your supervision. Give him the best chances. Also, some trainees better than probably, at least in my practice, better than me in their hands and the skills. But again, this is general rule. Let the most expert person to do the procedure. Then we need to look again to the preoperative precautions to define risk from the ocular pathology, eye pathology, for example, lid pathology, trichiasis, lid irregularity, conjunctiva, whether and in our population here, especially in the old generation, the conjunctiva has been what you call it, violated, or has been exposed to a lot of external issues like chronic inflammatory conditions, local therapy, and these things. So there is shortage of the conjunctiva is very not uncommon. So here you need to see, is the filtration surgery, for example, trabeculectomy or non-penetrating, is appropriate or not? If it is not appropriate because of the lid pathology or previous surgery or violated conjunctiva, or the conjunctiva has a problem, you need to go and use, for example, tube or even laser or something that you don't need much the conjunctiva. When I say the tube, probably you can go for other different quadrants, for example, for temporal or for nasal. But we know that the filtration surgery, whether penetrating or non-penetrating glaucoma surgery, is more safer, has been shown clearly that it's more safer when it's done in the superior quadrants. Again, sorry, short or long axial, as I mentioned earlier, for example, non-ophthalmos, high axial myopia, it's important to decide the type of anesthesia in the uh, uh, clinic. So such a patient, probably GA is much better. Certain types of secondary glaucomas. There are certain glaucomas that need a very, an expert person to do them. They are, the complication is much higher with them. For example, glaucoma associated with Sturge syndrome, we know the filtration surgery and how much the serious complication occurs with trabeculectomy. Has been reported when the trabeculectomy lacking its modification nowadays, and there was no non-penetrating glaucoma surgery. So in such patient and reports now showing that, as well as our experience that showing in stage over syndrome, which is a very difficult type of glaucoma, is need probably, or the most appropriate thing for them is non-penetrating glaucoma surgery. But if you are not familiar with this procedure, you can send him or send the patient to your colleague in the city, or if you want to do trabeculectomy, you need to take further precautions to prevent what has been reported from filtration surgery, such as, for example, gradual, as we will see later, gradual decompression, injection of viscoelastic material in the chamber to avoid collapsing of the or sudden hypotony. So this will minimize the development or occurrence of serious complication. Uveitic glaucoma also, in uveitic glaucoma, the most common type is open angle glaucoma, uveitic glaucoma. So again, has been shown through the literature as well as in our practice, non-penetrating glaucoma and open angle uveitic glaucoma, non-penetrating glaucoma surgery, and uveitic open angle glaucoma is superior to tube or to trabeculectomy. Neovascular glaucoma, these types of secondary glaucomas, most of the time you are working on them or you are taking them to the surgery with high pressure. So you need to be very careful in certain points. You need, for example, decompression of the globe, although you should do this as a practice, general practice for you, whether secondary glaucoma with high pressure or even in ordinary glaucoma with a pressure of high teens or 20s. Always make it your practice, a routine. So this is, you will not forget it or will not miss it, or will do a decompression, as we will see later on, slow decompression of the globe. Anti-glaucoma medications. Again, if you have a room or chance to discontinue all anti-glaucoma medication, all of them, as you know, they are changing, or most of them changing the profile of our cell profile in the upper surface, as well the congestion that is associated with them. Some of them, they may enhance the breakdown of ocular blood barrier. So if there is a chance to replace them with systemic medication, carbonic anhydrase inhibitor for a few days, a week or so, and to quieten the eye, this is probably more appropriate and give you a better chance for less bleeding during surgery, less inflammation after surgery. And again, sometimes I use topical steroids a week before or so to quieten the surface of the eye, so it make my procedure more effective. So these are general, or always you have to do these in the clinic. Make sure in the clinic you have, probably if you can do it, a checklist for that. Again, in the clinic, this is in the OR, this picture taken or this short video taken in the OR, but you can do this in the clinic also without even speculum. Just lift the lid and check the mobility of the conjunctiva, the vascularity of the conjunctiva, to see which quadrant you need to, or much better to do your surgery, superior nasal, superior temporal. For example, this is one of our patients. He had a glaucoma surgery before, trabeculectomy, but failed. But so we are repeating the procedure for him. So here you can see checking the conjunctiva. Yes, it is vascular because we are manipulating the patient before with gonioscopy and these things. So the mobility is fine and the conjunctiva is okay. So yes, decide which quadrant you're gonna do your procedure in the clinic. So don't wait until you reach the table or be on the table, so you might be surprised with something. So again, operative precautions, it's very important. Traction suture, you need a good exposure for trabeculectomy, for tube surgery, for non-penetrating, for these procedures. So the best exposures comes with probably peripheral corneal traction suture. Yes, there are concerns such as perforation of the cornea. If it's happened, it's easy, you know, it's not that a big problem, or you can do paracentesis and inject viscoelastic material and continue. You need the eye in its firm shape. So you can continue your procedure with the steps of the conjunctival exposure, scleral flap formation, and so on, whatever, or even exposure of a bucket for the tube surgery. Superior rectus, it always was being the traction suture in the past, but there are concerns. Now we are using it only, as for me at least, only in extracapsular cataract extraction. So concerns, you know, greater potential for bleeding, especially the subarachnoid hematoma, or the area surgical area hematoma of the surgical area, risk of ptosis post-operatively, and this is not uncommon. So nowadays we are doing it as only, at least in our practice, for extracapsular cataract extraction, which is very rare nowadays. So superior rectus is very simple, you know, it's very safe. This is, you know, a patient operated before, as I told you here, when you see the old trabeculectomy. Now, one catch with non-tooth forceps, and pass it slowly. It's very easy, very effective. You can expose the surgical field in a nice way without even damaging, even there's no hematoma, no blood here, no during, if you use tooth forceps, you will have either tearing of the conjunctiva, bleeding, and so on. So use either a Q-tip or even a non-tooth forceps. It's very simple. Then expose it to give you a good exposure. So traction suture and tissue handling are very important to avoid buttonholes that might occur with the tooth forceps, tears and hematoma of the conjunctiva, again with tooth forceps, wound gaping and ptosis later on if you are closing under tension of the conjunctiva. Again, you need to avoid also, this is a patient leaking after surgery because of a buttonhole. Here, the patient, probably the surgeon, he might be myself, or didn't evaluate the conjunctival mobility and so on, and did limbus-based conjunctiva and sutured with a spiral form. This is not, I mean, a good technique. This, I mean, conjunctival closure, continuous closure should be, I mean, or better to be a mattress continuous form. Though this is more physiologic and more secure. Again, don't use excessive cautery. Nowadays, with the use of antimetabolites, cautery with the use of antimetabolites, it may lead to shrinkage of the scleral flap. Also, excessive cautery, you need to protect your conjunctiva, not to be touched by the cautery with a waxel or whatever you need to protect it. So this is very important. This is how do I do the conjunctival flap. Yes, it is a little bit injected, but it is fine, mobility, and so on, and there is not much bleeding. And once you do it, go and take the tenon alone, about 2 millimeters from the limbus. And once you create a bucket of the tenon, hold the tenon, don't hold the conjunctiva, or hold both of them together. This would prevent tearing of the conjunctiva, or to be less traumatic to the both of them, less traumatic to the conjunctiva. So then, yes, dissect or make the bucket or the section on the other side. Yeah, probably, yes. So yeah, then catch the tenon also. Again, I think, yeah, tenon only. So this is will, again, save the conjunctiva from multiple traumas with your forceps and your scissor. This is very important thing. upper precaution again, scleral flap, radial incisions. What we are looking for? We are looking for a posterior blip. Why is that? Because, to minimize the possibility of late leak and possible infection, and dissecting a blip as well as overhanging a blip. This is one of our patients also. He has an anterior located blip, as you see here, thin cystic blip, dissecting blip, and you know what's happened here. And so what we need to have, this is one of our patients also, to have a posterior located blip as much as possible. See the scarring here because we scraped the limbus and we applied the raw surface together. So posterior blip will be less uh, 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 what we call it, less exposed to the multiple movement of the lids or the trauma by the lid movement, as well as during rubbing of the eye or so. So, and see the vascularity. He is not, he is avascular. Both of them, we used mitomycin C, but here the vascularity is much better. So be careful not to, or to avoid anterior-located blip. So this is with the modification, more field modification of trabeculectomy to avoid anterior-located blip. They recommend to be posterior to the limbus, about 0.5, 0.3 millimeter posterior to the limbus, and then make your radial incisions, So yes, half thickness, 1/3 of thickness or so. Simple. Use a wexel. Don't use a forceps to hold the conjunctiva. And then dissect the flap and try as much as possible to be one plane, not one area thin, one area thick, and so on. So this is very good or important point. This is what we have mentioned. So then careful use of antimetabolites. We are using antimetabolites in almost all of our patients. In the West, probably because they don't have the conjunctiva hasn't been subjected to multiple problems like chronic inflammation, glaucoma, and these things. Probably this will happen with us in the coming generations, as well as they're colored and their healing activity or is less aggressive than ours. So careful use of metabolites. So for example, the conjunctiva is thin, old patient, or there's a shortage of the conjunctiva, skip the mitomycin C. So before you use the mitomycin, check the mobility of the conjunctiva. Are you going to cover the surgical site with the conjunctiva without tension or not? Is the conjunctiva is good quality before you use the mitomycin C? This is very important. In some cases, although it's not our routine, we use sterile ointment to protect the conjunctiva rim, not to get saturated with the antimetabolites in thin conjunctiva, single-eyed patient, and those patients that really need an extra care. So this is very important. So then you use your mitomycin C as usual, and once you finish, irrigate thoroughly the remaining mitomycin particles or nucleus in the surface to enter the eye when you open the eye. Again, gradual decompression of the globe. This is very important, extremely important. As I said before, this can escape you a lot of post-op complications like decompression retinopathy, choroidal detachment and diffusion, and even suprachoroidal hemorrhage. So you need to make the eye adopt a new pressure slowly during surgery. So what you can do, you go and once you created your flap, you use the mitomycin C, you washed it out, go and decompress the eye through the paracentesis, let some aqueous goes out. And during this time, wait for a few minutes. During this time, you can pass your pre-placed sutures. Once you pass the first one, go and decompress the eye more, get another level of pressure, even if the pressure, as I said, in ordinary glaucoma, 20 or mid-20s, or even high teens, again, in a very fragile patient, old patient, most of them, this sudden decompression may have its deleterious effect on the patient or on the eye. So then decompress the eye, go and bump the other suture, and then before you go and create your flap, your fistula, decompress it again. Now we come to the fistula, size of the trabecular opening. Do we need, as we used in the past, Tommy's bunch 1/3 or so, or even more, or we need to get it less? If you used a large fistula with the use of metamycin C and the melting of the scleral flap after a while, this may, with large fistula, it may end it with a full thickness procedure or shape procedure, which is unneeded, which is dangerous. It is very risky for a complication. Again, in creating a fistula, where is the location where I'm going to put the fistula? I'm going to put it anteriorly or posteriorly. What do you mean by anterior or posteriorly? This is play a role in the incidence of hyphema in this procedure. So here, as you see, the pre-placed sutures has been already made, ready. So I go and create the fistula, and I will come to the fistula, whether anterior or posterior, and you can make your fistula with either with a punch, killy punch, or with balance or whatever. So once you did that, you go and do your opening. You did L shape. You do opening with killy punch, as you see here, 1 bite or 2. And this is enough. You don't need to have a large fistula. So it's enough, more than enough. And this will be protected. You know, the shoulders is very large, whatever the shrinking of the sclera will not reach, the flap will not reach here. The other important is not to make this, or to avoid buttonholes of the sclera flap and these things. So this will be protected, this fistula. So, okay. So then once you did see the pre-placed sutures are ready, then you can go ahead for the peripheroidotomy. Peripheroidotomy, don't delay as I did here. Once you did it, take the flap back, wash again, or you can delay washing later on, relax your traction suture, I delayed the relaxation. You can tab here later on, even tab on the limbus to get the view around and to see your iridotomy, but you can close before you do these steps. Hyphema, we came for hyphema. There is a nice article published in British Journal of Ophthalmology in 90s. They looked to the incidence of hyphema in a group of patients, 39 patients in each arm or prospective study. They look to the incidence of hyphema when they do they take the limbal block of tissue or the fistula tissue from purely corneal or corneoscleral. They found that the incidence of hyphema is much less when they take it from or pure corneal to rather than corneoscleral, which the incidence of hyphema was 56. So this is very important. Why? Hyphema is simple. I mean, sometimes it is a common in our practice. And most of the time it is not as severe, a significant hyphema. Little loud hyphema, so drained or cleared within a matter of few days, a day or 2 or 3, without sequelae on the patient vision or on the success of your procedure. So probably if it is more, this is the problem, grades here. So if it is more, imagine this is single-eyed patient and he has significant hyphema, it will blur him for significant time. In the same time, presence of blood, significant blood in the anterior chamber, and when it gets drained through the fistula, again, will invite more inflammation and more fibroblasts, and it might jeopardize your or the affect the your outcome. So yes, it is important to create the flap and do a tunnel here to get the block of tissue from the corneal, purely cornea. They, by the way, they studied the block of tissue histologically to make sure this is really a pure cornea and this is sclera has been involved. And they found that there is significant difference in the rate of hyphema between the two maneuvers. Okay. Then replaced sclera flap sutures, as I told you, is very important. Why? Because it's minimized manipulation in a soft eye. Imagine that the pressure is zero, the chamber is flat, and you are passing your sutures. Yeah, this is very injurious to the eye and very, and it will invite a lot of complications. So it's better to do it in a firm eye before you make the fistula. Avoid prolonged flat of the anterior chamber. It has a lot of problems when you get a flat anterior chamber. What we are doing here. Sorry, oh, I'm here. Okay, so avoid putting sutures after making the fistula. Do it before you do the fistula, or even in non-penetrating. This is a routine in our practice. In non-penetrating, once you reach this first bar, you go and do your pre-placed sutures, because it might happen. You are looking for a non-penetrating, but penetration, inadvertent penetration might happen, and then you will lose the chamber. So put the sutures, pre-placed sutures of sclera flap before you have penetration or before you have your fistula. This is extremely important. It's very helpful to close very quickly. And imagine this eye is vitrectomized. Once you open the fistula, the eye will collapse. You will see the cornea, emboing. So put the sutures. You say you may, I may use viscoelastic and prevent what you are talking about. Yes, you can do that, but it is, it is more safer, even if you use viscoelastic and manipulating in a zero pressure or a little pressurized eye, not as an intact globe. This is one thing. Then why I should viscoelastic? I'm not used to viscoelastic in my filtration surgery. It's costly and it's additional step. So I just put with the sutures and save the money for something more important. So then overfiltration. This is an extremely important step. Titration of sclera flap sutures. This avoiding overfiltration is the key to prevent majority of visually threatening early post-op complications. Shallow AC, flat AC, anterior chamber, choroid detachment, hypotony, maculopathy, cataract progression, formation, aqueous misdirection. All these happened with us. See, this is our patients, You can imagine, this is overfiltration and affecting the cornea. If this prolonged hypotony took a long time, this can affect the endothelial function also, not only straight keratopathy, but can affect endothelial function. Here, one of my patients, long time ago, we did a trabeculectomy in this patient. The vision before surgery was 20/20. 2 weeks post-op came with this picture: hand motion, low pressure, flat chamber, mature cataract. This is really a devastating complication. Yes, you can say, it's no problem. I can form the chamber and remove the cataract and so on. But definitely, yes, you can do that. But definitely, the endothelial density has been affected. Choroidal effusion or the detachment is not a major thing, but we can, as long as we can prevent it or minimize its incidence, it is preferable. Here, another severe or serious problem choroidal, hypotony maculopathy. In this patient, probably you can manage many things. Like in here, you have nothing in your hands, no tools, except to pray beside the patient. Yes, there's a palliative maneuvers until you take the decision to go and uh, 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 revise your probably or filtering procedure. Here, hypotony maculopathy, and then again, you don't know when you're going to intervene. And when you intervene, are you going to resume the function of the eye? The photoreceptors hasn't been destroyed. Yes, you can say that, you know, there are reports, Dr. Bedan, talking about correction of hypotony maculopathy 5 years after hypotony maculopathy, and they regain their full function. Yes, I agree with you. But there are cases that they haven't spent a long time, probably 6 months, and we have such a patient, or less even, and when we corrected this abnormality, they didn't regain their vision. So it is a serious complication. Here, aqueous misdirection. This is not an aqueous misdirection. Of course, this is probably a reduconial touch, but I brought it to, this can initiate a cascade of aqueous misdirection. So we can try, or we can avoid or minimize, I wouldn't say avoid, but minimize these complications by taking certain tips or peers in our procedures. So we'll make our procedure is more safe to the patient and less stressful to us. I'm not saying this will make the glaucoma surgery is complication free, but definitely if we follow these practical tips, definitely, and this is, believe me, this is, I found it myself. I have bought these problems, and now my practice changing by adapting to be my practice to follow these barriers and so on, minimize the incidence of these complications. Yes, it still can happen, but their incidence is much less. Yeah. So again, another important point to avoid overfiltration. This is how do we avoid overfiltration? By, you know, proper closure of this scrap flap. You can put two sutures only, and this is most of my time. But if you feel that still, you can add further sutures. So this is a patient after trabeculectomy, and then you pressurize the eye, dry, there is no spontaneous egression. Then when I press significantly on the beside the flap, there is egression of the flap of the aqueous humor. I don't do this in non-penetrating, of course. This isn't penetrating either. Trabeculectomy or penetrating deep sclerectomy. So in non-penetrating, I close the flap loosely, very loosely, as long as it is non-penetrating. But in penetrating, yes, I need to make sure there is pressurized eye and there is no spontaneous egression. And then when I press beside the flap, there is egression of the aqueous. So I would like to have a high pressure with deep chamber next day, rather than to have a shallow chamber or flat chamber with hypotony. You may say, okay, you are closing it very closely, no filtration, and your patient is advancedly damaged, his disc is advancedly damaged. Yes, you can do that and give short-acting aqueous suppressant, for example, carbonic anhydrase inhibitor, until you see the patient tomorrow. In the past, before the introduction of mitomycin C in glaucoma procedures, we are looking, we don't, at the final point in the past, when we close, we should see egression, spontaneous egression of the aqueous humor. Before even the suture lysis, before the antimetabolites become available or became available, we were, yes, looking for spontaneous egression of the aqueous and shallowing of the chamber on the table. But nowadays, no. In my practice, this is a very high or a good invitation for the early post-op complications. So it's very critical point. Then meticulous conjunctival wound closure. How? Protection of the wound edges from mitomycin C, especially in single-eyed patient, in thin conjunctiva, and so on. and posterior relaxing incision of the conjunctiva to avoid closure under tension. So even here you can do posterior relaxing incision involving only conjunctiva, sliding the conjunctiva anteriorly to avoid traction on the or tension on the conjunctiva, as well as scraping of the limbus to create a raw surface. So when you put two raw surfaces, the conjunctival surface, raw surface on the limbus, which is raw surface, this healing will be much better. And to remove the epithelium that has been touched by the mitomycin C. And then, of course, you can do fluorescein to make sure that your there's no leak. This is how to see that you are going to close the conjunctiva without tension. This is no tension, no significant tension on the conjunctiva. So this is fine. And then this is the scraping before you open the fistula, of course. This is when the eye is firm. So you can use any blade or even tooth knife, anything, to scrape the epithelium on the superior limbus. So when you bring the conjunctiva raw surface on the limbus, it will heal nicely, to avoid also the leakage and so on. So it is very important, very important. Okay, so then conjunctival closure, I try to escape this, so we'll save time to discussion or so. So now I close the conjunctiva. Okay, so I pressurize the eye. Then we form the blip. See, form the blip, and then we test with the fluorescein. This is your golden chance to correct any problem, not to be surprised next day with a leak. So pressurize the eye with BSS and form the blip, as you see here, with firm pressure on the side scalp flap, and then check for a leak. This is by what. So then this is your golden chance, as I said, to correct if there is any leak. Nothing better than this time. So then this is the patient operated before. This is the second procedure here, and this is next day. The chamber angle closure, the chamber depth is very beautiful. And this is 1 week, I think, is post-op, and peripheral chamber or mid-peripheral, again, angle closure. I accepted this depth. This is very fine, and he did very well. Then post-op, very important. They said the success of your procedure depends on this surgery, 50% on the surgery, and 50% on the post-op care. And this is quite right, quite right. So you need to keep aqueous flowing, massage, laser suture lysis, or removal of releasable sclera flap sutures. So, and to use topical steroids also for 6 or 12 weeks, depends on the situation or your healing process of your surgical site. Antibiotic prophylactic for a week or two. Psychoplegia in trabeculectomy alone, I always use atropine if it's available. In combined, I don't use it. And atropine is important to relax the ciliary body, to decrease the inflammation, to relax the ciliary body, to pull the the lens back, and to minimize the affection of the ocular blood barrier. And so, and also they said it stabilized they said have also some inflammatory effect. And this is based on one of my residents. He gave me this information last week or probably 2 weeks ago, Dr. Abdullah Turbank. I said, bring the reference here, Dr. Abdullah Sassid. So we are learning from each other, my dear. So post-operative care, again, careful checking for leak, intervention, timing. Look for the leak, there's no leak, and then the intervention time. You need an ocular massage, of course. You don't do it. Timing is very important. Suture lysis, I wouldn't do it before 2 weeks or so, but you can start with ocular massage, but don't do as AlObeidan. He's doing it second or third post-op day. Wait for 5, 4, 6 days until the injured blood vessels regain their integrity. And you can, if the pressure is high, you can use short-acting aqueous suppressants until you make sure that when you massage the patient, ocular massage, you will not have bleeding. So again, suture lysis, one suture at a time, and it's very important to not to cut two sutures and to even see the outcome when you cut a suture. Sometimes you may need to again massage after cutting suture and wait, and if there is a need, you can go and cut the other suture. So yeah, this is the way how do we do the massage. Q-tip or a Wexel beside the physical flap, press here, and you will see the, of course, before you do the massage, if there's underfiltration with deep chamber, very important. What do we need to do? What do we need to do, which is important? Before we do massage, we need to do colonoscopy to see what is the problem, what is the cause of underfiltration. Is it something closing the fistula, fibrin, blood, whatever, or due to my tight sutures? If it is due to my tight suture in appropriate timing, I can go after that and press on the sclera flap, and you will see the lip forming, and you can even repeat it many times in the next day or whatever, until you see that, yes, the massage is not enough. You may increase your steroids to minimize the inflammation. Then once you need to go for suture lysis, you can use this type of lens, Hoskin's lens, and cut a suture at one suture at a time, and hoping this will really have a good outcome. So in summary, with the available evidence-based evidence or reports, which saying that the superiority of glaucoma surgery to the usual therapeutic approach, medical therapy, laser therapy, then surgery, our approach in managing glaucoma needs to be changed. Really, it needs to be changed. And definitely, early surgical intervention have shown its ability, as I said, to the old conventional approach, and its advantage in the preservation of the visual function. And considering these practical tips on bills and glaucoma surgery would make the outcome safer and more effective. I would like to thank our great surgeon assistant, Christiane Twista, for her great job she's doing to us. Thank you very much. And if there is any question.
Thank you very much, Prof. Saleh, for the great presentation. And now we can open the floor for questions, please.
Yes. I don't know, I'm very disappointed from this, COVID-19 that's prevent us from interaction. Anyhow, I would like to hear questions, if there's any questions, or comment from my colleague, senior people, even junior people, if they have their comments or questions. It will be, I will be glad for that. Or probably they are.
Yeah, good afternoon, Dr. Saleh.
Good afternoon.
Thank you for this nice series and point in glaucoma surgery. I have a question about the applying mitomycin. Is there any difference if you apply this mitomycin before you do the scleral flap or after the scleral flap? Because sometimes they said about the fibroblast, and we have the problem mainly in the episcleral fibrosis, not on the scleral flap. So is there any difference to apply before or after?
Good question. Very good question. Very good question. Honestly, I never used it after the contractile flap dissection. I use it always after creating the flap, and we know one of the risk factors or the causes of failure is the fibrosis between the flap and its bed. When I put it under the flap, I'm not putting it only under the flap. Also, I put it under the conjunctiva and the tennis capsule. So the effect will be affecting the three layers, or at least the tendons and the scalp flap. So, and most of the failure, I believe, is the cementation, I can say that the adhesion between the flap and its bed. Somebody may say that if you apply it after creating the scalp flap, this may diffuse to the scalp body, the ciliary body, and so on. And I haven't seen a documented report that saying yes, this is can affect the ciliary body. What we need to avoid when we are doing non-penetrating deep sclerectomy, I use it when I finish the first flap. I don't use it after the second flap because what is remaining of the sclera is very thin, 50, 70 micron. And now, in this situation, it may get diffused to the intraocularly and affect the structures inside. Yeah. Mm-hmm.
Any more questions?
Please.
السلام عليكم.
وعليكم السلام.
يعطيك العافية بروف. معك أماني البكري من كيكس.
أهلا يا دكتورة أماني.
It's always great to learn from your experience. I would like to know more, what's the difference that you have experienced doing a deep sclerectomy in pediatric versus adult? And if you have any tips that can help us to decrease the failure rate, I would be happy. Thank you.
Your question regarding deep sclerectomy in pediatric glaucoma versus other procedures. Yes.
Versus, no, I'm in comparison to adult, Prof. Did you find any difference? Yes.
So what's is there a difference between the outcome in deep sclerectomy in pediatric compared to adult? Is that the question?
Yeah, that's one. And if there is any tips that can help us.
Yeah.
Thank you.
Thank you very much for this question. Yes, in pediatric glaucoma, we have a large experience in deep sclerectomy in pediatric glaucoma. And probably the largest series that has been reported in the literatures came from Saudi Arabia. The outcome, there is no difference between the maneuver itself or the steps itself between both in adults and children. And my fellow is here, Hanan, if she can remind me if there is anything. I don't think she noticed anything. So the outcome is quite good in both of them. The chance in adulthood glaucoma that you have extra tools in your hand that you may go for conjuncture, you may go for suture laxation, but it's infrequent. Conjuncture is frequent when you have some inadequacy in filtration. In children, I have no answer for that. Of course, you cannot do conjuncture, but probably what we see, what happens is a spontaneous conjuncture in most of the cases by the child when he rubs his eye in non-penetrating type. And sometimes we see abdrawn pupil to the surgical wound, indicating that the window, this window has been ruptured spontaneously by the child and invited the iris to be there. Sometimes doesn't block all the window, and the success rate is, we are so quite happy about the success rate of deep sclerectomy in children. And I think there is a study or a comparison between it and between the conventional way surgical management of glaucoma in children. We are waiting for somebody who's going to write it. We have a good number, and the impression is that if it is not superior to the conventional way, it is comparable, the outcome, at least, although we need to make sure that when we analyze the results, it is comparable to the conventional way, but it has a big advantage of much less complication in children with deep sclerectomy compared to conventional therapy. I hope this is answering your question.
Yes, thank you, Prof.
Okay, thank you. Any other question?
More questions, please.
Yeah.
Okay.
We have a
There are
question
no questions.
before a quiz is coming. So give us the questions. We may cancel the quiz if you are making us busy with the questions. Huh?
This is a nice offer.
Yeah. No more questions.
السلام عليكم بروف صالح.
السلام ورحمة الله. ريان شقيري again or?
راكان
أيوة راكان. أهلا يا راكان. أهلا. راكان الجريني. اوكي تفضل راكان.
الله يحييك. Thanks a lot for the presentation. Doctor, I have a question regarding the technique in surgery in DS. I'm not sure if we aim for higher filtration regarding the size of the flap, the circumferential size. If we increase it, I mean the width from, let's say, 4 compared to 5 or maybe more, does the exposure of trabecular descent window will aid in more filtration? This is question number 1. Second is the size of the thickness of the first flap or partial flap.
Which one? The first one or second one?
The first one. If we make it, let's say, we aim usually for almost like 1 or 2/3. Usually 1/3, Doctor.
Yeah, 1/3. The first one. Yes, go ahead.
So if we increase it a little bit, let's say 2/3, so the excised deep flap will be less in thickness, and this will create a smaller pocket. So does this may lead to less chance of filtration if we make the superficial flap thicker?
Okay. Thank you very much for these questions. First of all, the size of the flap. You know, the route of filtration in deep sclerectomy, non-penetrating deep sclerectomy, there are 4. 3 of them, I believe in them too much. One of them is the suprachoroidal or subchoroidal, suprachoroidal, or uveoscleral. This is the most important one. And this has been shown with UPM and so on. And this depends on the remaining scleral tissue covering the uvea tissue. So you need to be very deep in your flap. Not only that, but also your question size. It's better to go and create a large area. I prefer 5 or 6 millimeter scleral flap. So I can, in the superficial one, then I can leaving a little shoulders for the second flap. And then I create the second flap and have a good aqueous lake, what we call aqueous lake, through which the aqueous find its way outside the eye, either inside again through the subchoroidal, or the aqueous in the lake, as has been shown in animal studies, initiate formation of new intrascleral aqueous veins. This is very nice study, animal study by Andrea Marmouda and others in Switzerland. So, or we said that the root are all the subconjunctival, but main in deep sclerectomy is the subchoroidal and intrascleral roots. This is regarding the size of the flap. Yes, I agree with you. The size of the flap, I believe, although there is I'm not aware, at least probably, about studies regarding the size, but logically, yes, larger flap, larger floor, larger decompression space or aqueous lake definitely will help in improving the filtration. Regarding the size of the thickness of the flap, usually I do 1/3 as superficial flap to give a significant thickness for the second flap. When I remove it, I will have really a decompression space. So I remove 1/3 and leave the rest, or most of the rest is for the second flap to be removed. And then we leave just a thin tissue on the uveal tissue, about 50 micron, 70 micron. This will help in the filtration. The thickness of the superficial flap, does it have effect on the outcome? In trabeculectomy has been studied by my teachers, Karim Toma and Dr. Carl Traverso and others. When I was resident in the program, they found that they compared the thickness of the flap, the size of the flap, the shape of the flap, and they found that the significant thing in having or to have effect on the outcome is the thickness of the flap, of the trabeculectomy flap. The thinner the flap, the more the filtration. Shape or size doesn't have any effect on the outcome of trabeculectomy. But in deep sclerectomy, I believe if somebody gonna do such a thing, in 10 cases probably in each arm, probably will come with something can be informative to us. But I believe in larger flap in deep sclerectomy with thin remaining fibers covering the uvea is the most important drainage route. Thank you. Yes? Abdussalam?
Yes, I think we can conclude now, Prof. Saleh.
Are you
Thank
sure?
you very much for your presentation.